Good evening, ladies and gentlemen. Welcome to the 26th chapter of the Surgical Forum of the International College of Surgeons Indonesia section. My name is Peter Johannes Manopo. I'm the fellow of the Indonesian section, and I will be your moderator for this webinar. On behalf of the Indonesia section, I would like to express my gratitude to the World Office Bearer, Mr. Max Downham, the World President, Professor Lie-Kwan, and also our special guest speaker, the ICS, excuse me, United States section, the speaker of Dr. Domingo Alvear, pediatric surgeon from ICS-US section Pennsylvania, and also to the other speakers from the Indonesia section, Dr. Widhi, radiologist, and also Dr. Nyoman Putu, a plastic surgeon, and also to the Indonesian office bearers, Dr. Jani Dharmajaya, Professor Sri Maliawan, and all dear participants. So we come already to the opening session. For the next opportunity, I would like to invite the elect president of the Indonesia section, Professor Sri Maliawan. Professor Sri Maliawan, the floor is yours. Maybe later on, I will skip, and I would like to invite Mr. Max Downham, the World Executive Officer of the International College of Surgeons, to address the update of the International College of Surgeons. Mr. Max Downham, the floor is yours.
Thank you, Dr. Manopo. I'm greatly appreciative to you and the leaders of the Indonesian section for conducting these webinars. I think this is my 25th out of 26 total. And you always are very gracious to invite me to make a couple of comments. And first of all, to also welcome to Dr. Widhi and Dr. Putu Riasa, and to of course, Dr. Domingo Alvear, Dr. Maliawan, Dr. Arifin, Dr. Hendarto, and as I've said earlier, Dr. Dharmajaya. Welcome to you, and I commend the section for doing these webinars. And again, thank you. On behalf of World President, ICS-World President, Professor Lie-Kwan, based in Taiwan, and the other leaders of the international parent body, I thank you and do offer just 2 or 3 quick comments here. First of all, there are 2 meetings coming up in the Global Federation of the ICS. One is the United States section meeting being held in Providence, Rhode Island, I think April 28, 29, and 30. And second is the Philippine section mid-year convention, as they call it, which is on May 15, 2022, this year. And so those are current, forthcoming, soon to occur section meetings. I think on the membership front, we just brought back post-COVID 110 members of the Indian section, and I commend Dr. Raghapathi and Dr. Kumar, the leaders there, for that. We just introduced also 63 new members from the Nigerian section, and the Nigerian meeting, by the way, is scheduled in Abuja on June 8. And I believe that will be a hybrid meeting, as I believe all of these meetings that I've iterated will be. In terms of, so that's membership, it's meetings. We just spoke, Dr. Manopo, about the World Congress. For those who may not have heard or listened, I got on the conference call soon enough. We have currently 2 bids for the World Congress of the ICS in 2023, normally around October or November. One is from Turkey and the other is from Singapore. The International Executive Council, who has the responsibility for ultimately deciding the location of the Congress, will decide probably sometime soon after June 1. In terms of the efforts being made to assist the very regrettable immigrant and people migrating from the Ukraine to, I think, largely to Central Europe. Our European Federation Secretary, Dr. Izabela Shuchika, and other leaders, our first Vice President, and Professor Karol Nowak in the Czech Republic, Dr. Shuchika is in Poland, are doing major efforts, as is our world president, Professor Kwan from Taiwan. If there's any interest in that aspect, we have an official relationship with the World Health Organization. I've contacted Geneva, and they are basically directing that people who wish to contribute, at least with there are other entities, of course, involved, but at least with the WHO, that they do so via the country offices. So Dr. Manopo, thank you so much again, and the leaders of the Indonesian section for these terrific webinars. Welcome to the speakers, and thank you, sir.
Thank you very much, Mr. Max Downham, for your address on the ICS updates. And now we come already to the scientific session. For the first opportunity, I would like to invite Dr. Made Widiasih, radiologist, and she will speak on the role of MRI in brain tumor evaluation. Dr. Made Widiasih, the floor is yours.
Thank you. I would like to share my presentation first. Can you see it?
Yes,
Dr.
clear. Yeah, clear. Would you please put in the full screen? Okay. Okay. Thanks. Yeah. Thank you.
Okay. Thank you, Dr. Peter, as a moderator. Thank you for ICS for inviting me to be a part in this webinar series. I'm Dr. Widhi from the Sangla Hospital, Denpasar, Bali. Today, I would like to share my experience in radiology, especially the role of MRI in brain tumor evaluations. For the introductions, the development of radiological imaging techniques has progressed significantly in recent years. MRI is highly sensitive to pathologic alteration of normal parenchymal and has been an important diagnostic tool in the evaluation of intracranial tumor. MRI also allows an accurate determination of lesion location, extent, mass effect, and infiltration of important structure. We know conventional MRI provides the anatomical and structural details of lesions. However, its specificity is limited. As a result of diagnostic uncertainty, and patient will undergo invasive biopsy of brain lesions, which is not without risk. New advanced imaging MRI techniques can provide more detailed characteristic of brain tumor, so give us more choices of appropriate therapeutic management of the patients, and also play a significant role in monitoring of the effect of the therapy. The objective of the brain tumor imaging can divide into three items. The first is for the diagnosis by distinguish about the tumor versus non-tumor lesions, and also to define about the histological grade. And the second for the treatment plan by delineation of the tumor extent and also to distinguish tumor versus peritumoral edema. And the third is for post-treatment follow-up by differentiated about the residual tumor versus treatment necrosis, and also to distinguish about the progression versus pseudo-progression lesions on the patient post-treatment. Before I talk further about the how MRI can help us to evaluate about the brain tumor, it's good for know about the advantage of the MRI. Unlike a CT scan, MRI does not use ionizing radiations and is thus preferred over CT in children and patients requiring multiple imaging examinations. MRI has also has a much greater range of available soft tissue contrast, depict anatomy in greater detail, and is more sensitive and specific for abnormalities within the brain itself. If we need to add the contrast, difference with the contrast on CT scan, some studies has stated that the MRI contrast agents have a smaller risk of causing potentially lethal allergic reactions. And then MRI also can the evaluation of the structure that may be obscured by artifact from bone and CT image. Similar from the CT scan, MRI is also performed by sagittal, axial, or coronal sections, which very helpful us for the delineation of the lesions more precisely. To about the conventional MRI techniques. These techniques provide information about the anatomical condition of brain tissue, the tumor itself, and its relationship with its surroundings. These techniques are significantly more sensitive than CT, but they often provide limited information about tumor physiology. For the diagnosis of brain tumor, the conventional MRI protocol includes T1 weighted image, T2 weighted image, flare, gradient echo, or SWI on 3 Tesla MRI, and also post-contrast T1 weighted image. In some cases, visualization of brain tumor in non-contrast imaging can be difficult. Therefore, administration of paramagnetic contrast agent is necessary. Enhancement is seen when a brain tumor destroys the blood-brain barrier. Contrast enhancement of brain tumor is variable and dependent on tumor neovascularization. Unfortunately, some non-tumor lesions can enhance because they can also break down the blood-brain barrier and may simulate a brain tumor, include infections, demyelinating disease, and infarctions. And it is very challenging for the radiologist to be able to distinguish about the tumor from the other mimicking lesions. This image show us how the importance to perform the contrast administration on the MRI. From the axial T1 without contrast, we just only seen about the hypointense lesion on the left parietal lobe with indistinct border. But if after we add the contrast, we can delineate the lesion more clearly. We can measure about the size and also analysis about the extension of the lesion to the adjacent structure. Now I will talk about the MRI techniques and their purpose in brain tumor imaging. It's different from the CT scan that only analyzes characterization of the lesion by look at about the S density. But on MRI, we should be analyze all the sequence that we have. For the first, about the T1 with the image. This sequence is used for evaluate tissue architecture and good delineation for anatomical structure. In general, all the lesions on the pre-contrast T1 will look hypo-intense in T1, but some lesions can also see hyper-intense, especially if the mineralization, fat, or melanin. On T1 with the image can also perform by edit the contrast because the post-contrast enhancement will make us to give the clearly about the lesion. The second sequence is T2 or flare. This analysis about peritumoral edema that always usually combine the lesions. On the T2, or usually in general, all the lesion looks hyper intense, but some lesion can also look hyper intense on T1, especially if the lesion contain with the blood product, on the fibrous lesions, on the tumor with a high cellularity, and also in the vascular blood flow. The next is the T2 star, or susceptibility weighted image on 3 Tesla in MRI. This sequences is so in this sequence we can analyze or evaluate about the blood product inside the lesion, but better for us to compare with the PACE image on the 3 Tesla MRI to differentiate about the blood product with the calcification that always give the appearance hypointense on T2 star. This is the image that show us that the T2 or and flare sequences is very good for find out about the lesions, because in some minimal small lesions sometimes we very difficult to find out about the lesion, but if we based on the peritumoral edema, we can focus on the area to find out the lesions. Now I will show about the case in our hospital, a 46 years old woman with seizures from the T1 with an image without contrast. We've seen there is lesion or mass on the right parietal lobe looks hypointense with the hyperintense component in the central of the lesions that becomes a hypointense on T2 with that image. If we're dealing with this lesion, we must talk about the blood product inside the lesion. So we need the other sequence like SWI to prove our susceptibility about the blood product. And if we seen a hypointensity on the SWI, we're dealing with the blood product, but we still better to distinguish with from the calcification by the compared with the PACE image that only have on the 3 Tesla. The next technique advanced MRI SDWI is sequence or the techniques for random motion or diffusion of water and can be presented as the high cellular usually shows the restricted diffusion or high signal intensity in the WI. But some non-tumoral lesion like infection or abscess can also show the restricted diffusion on the WI. So we need to add the other advanced imaging for distinguish about them. The next technique is MR spectroscopy. This technique can assess tumor biochemical or metabolic profile by the analyze about the peak of the choline, NAA, creatine, and also lipid and lactate. On the higher grade glioma, will show higher choline, NAA, and choline creatine ratio. Lactate peaks are not normal, and this is the repression, necrosis, and hypoxia inside the lesions. The other case is 46 years old man with complaints weakness of right extremity. From the axial T2-weighted image, we can see about the single lesions on the left frontoparietal lobe looks hypointense in the periphery and hyperintense in the central, accompanied by the perifocal edema. On flare, we seen that the lesion become hyperintense on the periphery and hypointense on the central. And after we inject the contrast, we can see there is smooth ring enhancement, contrast enhancement on the lesion that lead us to think there is the benign lesion, because the rim is very smooth, but we must considered to perform the other advanced imaging like MR spectroscopy to prove our diagnosis. And from the MR spectroscopy, then we perform shows that this choline creatine and choline NAA is high. That means that the lesion is malignant lesions. So we conclude there is the high rate of the glioma and pathologic anatomy. Glioblastoma, W width is O grade 4. The other technique is MR perfusions. MR perfusion can be done with three techniques. This is the DST, DCE, and IL. DST usually used in the intraaxial brain tumor, which is assess about the cerebral blood volume. Higher blood volume suggests higher grade or progressive or recurrent. Is dynamic contrast enhancement or DCE. This technique usually used in extraaxial brain tumor or for the tumor and the other part of the body, like a musculoskeletal. On DCA, we evaluate about the volume transfer constant that describes about the wash-in rate and wash-out rate of the contrast and the lesions, and also we can measure of the permeability, the presence of vascular leakage of the lesions. The high permeability suggests high grade technique that we the perfusion is arterial spin labeling. This technique is performed without contrast, and we assess about the cerebral blood flow. Higher blood flow can be used also for tumor grading. This is the case, the other case from 66 years old woman with right hemiparesia and headaches. From the axial T1 weighted image without contrast, we see the big mass on the left temporal lobe until the gain of corpus callosum that shows a hypointense with the hyperintense component inside the mass. That become hyper intense, slightly hyper intense on T2 with it image with the hypo intense component inside it. From the WAI, we saw that the lesion appears the diffusions that compare with the low ADC. I've already deal with the appearance of the malignant lesions, but it's better for us to also perform the other advanced MRI for prove our diagnostic. And we also perform MR spectroscopy and MR perfusion to the lesion, and we saw this that is the lesions. So the choline creatinine and choline NR ratio that it's high than normal, and also increasing of the blood volume in the tumor area compared with the normal brain parenchymal. And we also conclude that the lesion is malignant high-grade glioma, and the pathologic anatomy is also confirmed that it is glioblastoma. The next case is 48 years old male with cognitive impairment and history of lung cancer. From the T2 axial weighted image, we just only seen about the slightly hyperintense lesion on the left frontal lobe without mass effect to the adjacent structure. From the flare, we seen that this lesion become hyperintense and also hypointense peripheral. From the SWI, we seen there is a blooming artifact or hypointensity inside the lesion, mean the lesion is contained by a blood product. And object the contrast, just only seen but minimal leptomeningeal enhancement on the peripheral or the lesions. And from only based on the imaging, we still doubt whether there is the metastatic process or only inflammation process like early cerebritis. So we need to continue the examination with the advanced MRI. And from the MR spectroscopy and also MR perfusion, we seen there is the lesion is also malignant lesion because has the higher choline creatine and choline NR ratio, and also increasing of the blood blood volume in the tumoral area. So this the pathological anatomy is also confirmed there is the metastatic lesions. The other case, a 50-year-old man with left hemiparesis. From the axial T1 with contrast, we seen there is a mass on the left temporal lobe with the irregular peripheral enhancement, and then with where if in the blood perfusion, we seen there is blood volume of the lesion is very high compared with the normal parenchymal. In so this means there is a lesion is also high grade of the glioma. The next case is 9-year-old boy with ataxia. From the T1 with that image without contrast, we seen the lesion with indistinct border on the left posterior fossa from the recess of the fourth ventricle until left CPS cisterns looks hypo-intense and also iso-intense of the lesions and become hyper-intense on T2 with that image. On DWI, we see there is a part of the mass looks restricted diffusion that compared with the low ADC. And after we inject the contrast, we see there is the lesion appears that the irregularity of the enhancement of the lesions that leads us to suspicious about the malignant lesions of the posterior fossa, but it's better for us to continue with the other examination. So from the MR spectroscopy, we saw this the lesion didn't show high creatinine and choline NR ratio, and also the peaks high lipid and lactate peak. So there means there is no high grade lesion, high grade malignant lesion. So we conclude there is a low grade lesion. Then and the pathology anatomic confirm there is ependynoma or the SWHO grade 2. So we see that is very useful for us to continue with the other advanced MRI imaging for distinguish about the lower end grade tumor. The next technique is DTI or diffusion tensor imaging. This technique can analyze about the orientation of white matter toward the lesion. Very useful for the surgical planning because from this technique we can determine whether the white matter tracts is only displaced or compressing have already inflated by the tumor. And the last technique is functional MRI. From this technique, we usually detecting alteration at blood oxygenation level, and functional MRI can determine us about the part of the brain that handling critical function that should be avoiding during surgery. So functional MRI is also useful for surgical planning. The next case is 12-year-old boy with right hemiparesis and seizures. From the T1 with the image without contrast, we seen in the deep temporal loop, left temporal loop, the mass that looks hypo-intense with the hyper-intense component inside it that becomes slightly hyper-intense with hypo-intense component inside on T2 with that image. And we confirm from the SWA, there is a blood product inside the tumor. From the MR spectroscopy, we proven that there is the malignant lesions because we saw there is choline, creatinine, and choline NR is very high. And also from the MR perfusion, we seen there is a blood volume of the lesions is higher than the normal brain parenchymal. So this is the high grade glioma, WHO grade 4. For the surgical planning, we also add DTI for the patients to evaluate or to analyze about the wet matter tract. And from the TI, we can see there is the tumor only displays a wet matter tract without infiltration of the wet matter tract. So it's very good for determine about the effect of the tumor to the wet matter tract. This is the other case that I took from the journal that show there is the mass on the right occipital lobes that is, and also infects a part of the optic tract on the right side. And from the MR spectroscopy, it's very suggestive for the malignant lesions because reveals choline, creatinine, and choline NR ratio that was high. The next I will also show about the role of the MRA and follow-up of the treatment. This case also I took from the journal from the patient with the glioblastoma on the right parieto-occipital lobes that have already done the surgery. 1 month after surgery and after chemoradiation, we seen there is increasing of the size of the tumor and also increasing of the enhancement of the lesions. So ADC is also reveals the lower ADC. That means there is increasing or progression of the lesions. It's also supporting by MR perfusions that shows the increasing of the blood volume and the lesions, and also on the MR spectroscopy we can see about the increasing of the choline and choline ratio, choline NR ratio. This means there is progression of the lesions. 6 months after the last MRI, we seen there is the lesion become progression about the lesion, the size also of the concluded is the true progression of the lesions. In the last case, I will show this is stoma on the deep right parietal lobes, looks hypointense on T1, and this is 1 month after the patient got the chemo radiations. We looked strong enhancement on the lesions, but from the ADC, we cannot see about the low ADC that lead us to the malignant lesions. So if we perform the other MR perfusions, we also cannot see about the increasing of the blood flow and these lesions. And also in MR spectroscopy, we didn't see about the high choline creatinine or choline NR ratio. So it's mean that the progression of the lesion. So this is the only the pseudo progression. So it's mean it's very expenses of the technique of the MRI for determine or distinguish about the true progression and also pseudo progressions, and because it will give the clinician for the planning treatment. For the summary, neuroimaging plays an evolving role in the diagnosis, treatment planning, and post-therapy assessment of brain tumors. A significant factor for success in the treatment of brain tumor is the determination of the extent of the tumor and infiltration of important structure. MRI is a powerful and flexible instrument for evaluating patients with brain tumor, and advanced MRI techniques in conjunction with conventional from non-neoplastic lesion in the brain. And it also helps in the grading of the tumor, selecting biopsy targets, particularly in non-enhancing lesion, and assessing treatment response. Thank you very much for your attention.
Thank you very much, Dr. Madi Widiasih, for your very informative presentation. We will have discussion after all presentation will be completed.
Thank you.
For the next opportunity, I would like to invite our guest speaker, Dr. Domingo T. Alvear, FICS. He is a pediatric surgeon.
The way down?
And he will talk on the superior
Where?
mesenteric artery compression syndrome. Dr. Domingo T. Alvear, the floor is yours.
Thank you. Slide share.
Slideshow. Up at the top, Dad,
Where?
in the menu. Where it says slideshow, you know how to do this.
Oh, here.
Yeah, that presenter. And now you gotta share the. No, all the way to the top bar, and you gotta get the menu. Just go to the right. And go all the way to the top. Where's the Zoom menu? We'll pull it down. Why you have to do it that way? It's backwards. Did you just get booted?
I don't know.
I think you got booted. All right, fine. Come back.
At the meeting.
Dr. Alvear, just in case, if you need the committee run the slides for you, they will do it for you. Yeah. Your slides is on the screen already. Excuse me, Dr. Alvear, I cannot hear your voice. Maybe your microphone still muted.
Start all over. Hurry up.
Hold on. is it?
No, yeah, that's it.
So ask him.
Hello, can you hear me now?
Yeah, very clear. And
Oh,
also your slide
yeah.
is clear all too.
Okay, thank you.
You're
We
welcome.
got, this is a superior mesenteric arc compression syndrome, and it's been known for some time, but there's still a lot of confusion as what to do with it. So we talk about the history, theology, pathophysiology, presentation, then diagnosis and treatment options. This has been known since 1754 by Boner, and describe a young female with the pain and the vomiting of bilious material. But it was Boner-Kotansky in 1861 who did autopsies on patients with this syndrome. And since then, there have been some confusion as to how to diagnose it. And the treatment, surgical treatment, was first described in actually 1908 by Stabley, which I'll describe later. It became known as Wilkie syndrome from 1927 to 1960, but there's still some skepticism because there was no way of diagnosis until the 60s when they created the so-called hypotonic dunninography, which I'll describe later. And then, of course, CT scan showed up in the 80s, and then it became more widely accepted. And finally, in 2001, 3D CT angiography was discovered, and this created the definitive diagnosis for the syndrome. What causes the syndrome? Is there a congenital predisposition? And I'll talk about that in a little while. However, during my observations, I find that when a patient has a linear growth spurt during adolescence without increase in abdominal girth, this is a predisposition. Now, the most commonly used cause for this was excessive weight loss, and that's why they have the so-called mesenteric fat as a cause. However, not everyone that have lost weight has SMA, so there must be some other predisposition. It's also been called a cast syndrome at one time because when patients had injured and they were put in a batic cast, or if they have scoliosis surgery, then they develop the syndrome. And scoliosis surgery, we'll talk about it later. There are articles in the literature that will describe potential congenital predispositions to the syndrome, including ours that we published in '89 and then 2008. There's a talk about the ligament of Treitz. If this is short or thick, it could be a predisposition. The other one that's involved is the presence of the elongated mesentery, which can cause a torque effect and cause heaviness to the superior mesenteric artery. What's most important here is the patient has a so-called asthenic build, which is a very thin patient with the distance between the back and the chest wall and the abdominal wall is short. The most commonly mentioned is the loss of mesenteric fat or retroperitoneal fat. This is why most people would suggest allow the patient to gain weight, but that doesn't always work if there's really a congenital predisposition. What's the prevalence of this condition? The most commonly used statistics is 0.13 to 0.3% of the population. However, some other journals now have suggested maybe it's higher than normal, like 4% population may have the disease. And then, of course, the most commonly found age is between 10 to 39, but it's been found in the newborn, even discovered prenatally, and then and also in the elderly. More frequently in females than in males. What are the pain is the most frequent symptoms that's seen can be very severe and debilitating, And then the question is, what comes first, the psychosomatic symptom, or is it the pain? This is where the difficulty is, because the patients get discouraged, and then the doctors who are treating the patient also get discouraged. They don't know whether the patient has psychosomatic problems or real problem. And etiology of the pain is not well known. It's not well described. Even if you read the book or the literature, it doesn't tell you. But I suspect maybe it's the pulsal compression, the SMA against the duodenum. And also because of the partial obstruction, you can have distension of the proximal duodenum with a to and fro motion, which is the abnormal peristalsis. And then, of course, if there's an associated delayed gastric emptying, the stomach can have abnormal contractions. Now, is there transient ischemia? We don't know. So these are the things that I've observed. The asthenic build is very common, 80%. And you find, if you listen to the abdomen, you might find a Roux-y. This can also be seen in median arcuate ligament syndrome. If the stomach is full, you'll have a so-called Sacosian splash. The syndromes associated with SMA include the nutcracker syndrome, which I'll describe later. You can have collagen disease like Ehlers-Danlos syndrome, and then you have some occasional postural or orthostatic tachycardia syndrome. But the ones that I've seen associated with SMA is the median arcuate ligament syndrome. A nutcracker syndrome is when the renal vein is also included in the action, but it's not for everyone, only a few. And I'll describe this later. Of course, when you have difficulty in eating and digestion, and then of course absorption, you'll have malnutrition, and this has become fatal in some patients, and it's not well described. What are the diagnostic studies? As I said, the gold standard now is the use of 3D CT. But there have been, we've done it in the past, the upper GI series, I'll describe later. EGD is operator dependent. If the gastroenterologist is very acute in their examination, they can do this. Patients can have delayed gastric emptying, so you must do the study. High-res scan is important because there are associated biliary dyskinesia with these patients. A Doppler ultrasound becomes important when you're dealing with patients with median arcuate ligament syndrome, because there'll be some disparity in the velocity of the sounds, especially with expiration. And then for those patients who are allergic to the dye with the CT, you can use MRI. The old study was the use of the upper GI, which is done carefully, because if you use a routine upper GI, you can't do it. You must be very careful to watch how the progression of the contrast into the duodenum, and you'll see a cutoff of that dye, or you can have a filling defect. And this, you can control this then by positioning the patient. The dye will pass through that cutoff area, and then of course you can see delayed gastric emptying within 6 hours if there's an obstruction. The 3D CT is the gold standard now, and this you can examine the angle between the SMA and the aorta, and you can also the distance, and the normal angle is 25 to 60 degrees, and below that is abnormal, and the distance between the aorta and SMA would be 10 to 28, and those below that is abnormal. A classic finding is, you can see here, the stomach is usually distended, and then you can determine the distance between the abdominal aorta and the SMA, and then the pinching of the duodenum. And you can determine the angle. As I mentioned, the angle normal is over 20 to 60 degrees. And I've seen massive gastromegaly in patients with SMA that have chronic, been there for a while. The MRI will do the same thing. We'll show you the cutoff of the in the area of the third portion of the duodenum. Now, can you live with SMA? Yes, you can. If you learn how to eat properly, you can have frequent small meals, and don't drink too much in between, and do postural therapy, and then you supplement yourself with some high calorie feeding. And those patients who can't do this, then you resort to NJ feedings. You put the tube beyond the obstruction, and you feed them through the NJ feeding. But if that doesn't work after 6 to 8 weeks, and you reassess the patient, and they still have a lot of symptoms, especially with vomiting, bilious vomiting, and pain, then you resort to surgical procedures, which I'll describe later. Gastrojejunostomy has been used in the past, but this is no longer used because it has complications like dumping syndrome, and you can have bile reflux, and then you can have ulcers. The other procedure that's been proposed is the so-called strong procedure, where you divide the ligament thrice to lower the duodenojejunal junction, and also to get it off the SMA. However, problem with this is that there could be a kink in that area, and there'll be recurrence of symptoms. The first duodenojejunostomy was described by Stabley in 1908. And you can see here it was rather complicated. He divided the duodenum and then reanastomosed it to the other side, but the obstruction remains. You can see the SMA remains in the same place. The current, the most popular procedure today is the duodenojejunostomy, and this is done retrocolic loop of jejunum placed into the duodenum. But again, you can see that the obstruction remains. A procedure described in China, so-called duodenocircular drainage procedure, is almost like, it's like a Roux-y. And some people have used this, but again, you can see that the SMA remains compressing the duodenum. So the problem with any bypass procedure is that the presence of the SMA still compressing the duodenum, and you can have delayed gastric emptying, and then you can also have diarrhea due to dumping. Other procedures that were described in the literature I'll describe later. As you can see, 3 procedures. The first one is the anterior transposition, where the duodenum is divided and then transposed anterior to the SMA. This was described by Duby from Nigeria from he did 10 patients from 1977 to 1986. And this was duplicated in Japan in 2007 literature. And but I don't have long-term results on that, how the patients are doing right now. And then Dr. Ang from Ocala Medical Center in Florida, they found, did the same thing we did, which is divide the ligament thrice, and then they did a staple anastomosis between the third and fourth portion of the duodenum to allow the food to go through in a straight manner on the right side. And then he's been doing quite a bit of procedures now. So we will be comparing notes in the future. Dr. Sandman in Germany performed what's known as infralinear transposition, where he actually divide the superior mesenteric artery and then anastomose it back to the aorta below the duodenum. And this is rather very complicated, and you have to be a very good surgeon to prevent problem with the SMA. They put heparin to prevent clotting. And again, this needs long-term study. The patients, I mentioned the Roux-y gastrojejunostomy. And then we have whenever there's a problem with the kidney, they have to perform different procedures to help that. And of course, if there's a biliary dyskinesia, you perform cholecystectomy with the operation that you perform. I come across a procedure done in Singapore by Dr. Wong. One patient called me and been communicating with how she's doing. They did a segmental resection of the duodenum actually, and then reanastomose the duodenum to the side. So far, the patient this operation was performed in the beginning of the year, and so far she's doing well. So I'm gonna be following this patient, see how she's doing over the next year. We have two publications, one in 1989 and the other in 2007. So this is the experience of 37 patients, mostly females. As you can see there, the abdominal pain is prominent and nausea, but only 12 had vomiting. Early satiety is because the stomach is always full, so they can eat very much. Weight loss is not always present. One patient had prior strong procedure with recurrent symptoms, and one patient had prior duodenojejunostomy bypass. What I do is I do a small right upper quadrant incision, and then you can mobilize the colon, and you can bring the entire colon up, and you follow the principle of the LADS when you do malrotation. And with that small incision, you can actually bring after immobilizing the colon, you can see the duodenum behind, and you can see the ligament of Treitz. You then divide the ligament of Treitz and you derotate, I call it, I derotate the duodenum so you can bring it out of the SMA. And when that's completed, you can see there's still some kink in that duodenojejunal junction. So you continue to divide all adhesions. Oh, it doesn't move. Not moving. Get frozen. My slide got frozen, so let me see if it. Oh, there you go. I got it. After the rotation, you must. This is what it looks like after lysis the adhesions. You can see the duodenojejunal junction looks now straight. What you then do is you fix two areas, duodenojejunal junction, and then the cecum to the ascending colon to prevent volvulus. If there's a kink like this, you have to do a duodenojejunostomy at the site, side-to-side duodenojejunostomy. Just make an opening after the serosal sutures. That's a completed anastomosis. And the upper GI after the, you can see this, this is what it looks like in the upper GI series. And the results, we had 34 patients requiring derotations, and 4 of them had duodenojejunostomy because of the kink. And then I had to do another two more duodenojejunostomy, a total of 6. And those patients who had delayed gastric emptying, we perform what's known as an enterotomy, which is a splitting of the muscle proximal to the pylorus, not a pyloroplasty, an enterotomy. And all patients are doing well, except for one who had gastroparesis. And here's a collage of those patients. And for the gastroparesis, it's not the same as what you describe in the literature as seen in diabetic patients. These are because of perhaps gastric atony from gastromegaly. And also some of them had opioid dependency, and some of them had associated median arcuate ligament syndrome. The treatment through medications is not always effective. People have tried Botox injection into the antrum, also short effectiveness, 3 months to 6 months. Some perform laparoscopic pyelomyostomy by balloon, and then some perform, lately I've seen sleeve gastrectomy as one of the treatment for severe gastroparesis. Gastric pacing is when you put electrodes into the stomach, also with mixed results. We have to consider median arcuate ligament syndrome, where there's a obstruction of the celiac artery in that area. And you can see this by Doppler ultrasound, and you can see the obstruction during expiration. Similarly, CT scan or MRI can detect that. And once you release it, you can see release of that obstruction of the celiac artery. So what do we need for the clinic? You need a team approach, someone who can be in charge of the patient, and you need help of gastroenterologist, dietitian, nutritionist, the pain management specialist, especially can perform blocks. And then of course, you need a psychologist or psychiatrist and social worker or clergy. They now have a SMA syndrome organization in the US, and I'm the medical director. And now they also have a national organization for rare diseases, for which I became the editor for their for the SMA syndrome. So in conclusion, this is a true disease entity and yet still confusing. The diagnosis is made by 3D CT or MRI, and I propose the procedures that so far is most effective is duodenal derotation with fixation of the digit junction and cecum. And if there's a kink, a duodenojejunostomy is required, and then antrotomy if there's a delayed gastric emptying, and then of course divide the median arcuate ligament if there's associated celiac axis syndrome. So this is my proposal. We should do more research, and we have to determine the true incidence, the timing for surgical intervention, and then long-term results for any surgical procedure. Thank you.
Thank you very much, Dr. Domingo Alvear, for your great presentation. We will have discussions later on. And for the next opportunity, I would like to invite Dr. Nyoman Putu Riasa, a plastic surgeon, and he will talk on the surgical management of hypertrophic scar and keloid. Dr. Nyoman Putu Riasa, the floor is yours.
Yes, thank you, Dr. Peter.
Thanks.
Maybe we need to close the Dr. Alvear screen first.
Yeah. Dr. Alvear, would you please take down your slides because will be replaced by another slide.
Okay, sorry.
Yeah, thank you.
I get it. I'm getting it out. Oh, there, I got it. Is it out?
No, no, still exposed, still there.
Oh my. I have to get my something's.
Just yeah.
On the upper part of the screen, you will see stop share.
Oh, stop share.
Yeah,
Okay.
stop share.
Okay, I got it. I see it. I have two monitors here, so I'm
Yeah.
okay, got it. There.
Thank you.
Good.
Thank
Okay,
you, Dr.
sorry.
Yeah,
Alvear.
perfect.
It's okay. It's okay.
We have to learn all this.
Yes.
Okay.
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 I will. Sorry. You could see my slide, Dr.
Yes,
Peter?
clear. Yeah. Also, your voice is clear.
Thank you. Yeah. So thank you very much to Dr. Peter Manopo who invited me to, and Prof. Sri Maliawan too. Yeah. This is the request topic regarding surgical management of hypertrophic scar and keloid. Yeah. So I will try to explain maybe much more on the surgical procedure according to the request. Yeah. So hypertrophic scar and keloid is actually a fibroproliferative disorder. This is caused by abnormal healing of injured skin or irritated skin. But the difference is only on the duration of inflammation and also the intensity. That is the difference, but the same pathology. Some risk factor like genetic and then systemic and local factors is also contribute to the development of the scar and keloid. Until now, the treatment of option that is available is surgery, the use of corticosteroid, and fibrouracil, laser, cryotherapy, yeah, anti-allergy, anti-inflammatory, bleaching, and radiation too. Yeah, but we are here in Bali. We only use surgery and corticosteroid, 5-fluorouracil, that is they are available in our hospital, anti-inflammatory, yeah, and anti-allergy. But radiation not yet come to our treatment of option. The epidemiology of hypertrophic scar is mostly happen in burn injury. So after burn injury, almost 91% of burn patients develop hypertrophic scar. Yeah. But keloid is different. Keloid has a race tendency. It is mostly common in Asian and African population. And also the keloid has a location of predilection, like auricle, deltoid, peristernal, and joint. So what happened actually in keloid and hypertrophic scar? As we know together that wound healing is could be divided into inflammatory phase, proliferative phase, and maturation phase. So the keloid development is start from the beginning. Hypertrophic scar development is start from the inflammatory phase. So this is why we call it inflammatory fibroproliferative condition. The inflammation, especially on the reticular dermis, if it is prolonged, that will produce more severe hypertrophic scar and keloid. So our target is how to reduce the reticular dermis inflammation. And also excessive fibroblast proliferation with matrix accumulation is also one of the characteristic of hypertrophic scar and keloid. And until now, it is known that the receptor TRPC3 is like a mechanical force transducer. So it's mean that the contracture that develop in hypertrophic scar especially is has a transducer, mechanical transducer, the receptor, and it's affecting the fibroblast secretion, increase the fibronectin. Another cell that is important is myofibroblast. This myofibroblast has a contractile ability. This really affecting the severity of hypertrophic scar, especially. And tension on the wound and also on the immature scar, it also can prolong inflammation. The active region of the body that also will prolong the dermal inflammation. So we call it inflammation-driven pathological scarring. The strategy in removing the keloid or hypertrophic scar, we have until now two strategies. First is total excision of the hypertrophic scar and keloid. It is we choose this technique on especially in small lesion, but not lesion too. Yeah, if the scar or the tissue is ulcerated, stiff, hypopigmentation, inflammation, and also if there is a like a squamous cell, of course we will remove much wider. Yeah, and the third is release or contracture. We should perform in all direction of the scar contraction. And then the second strategy is partial excision. Yeah, focus on removal of the central fibrous part. So we call it core excision. Yeah. And this is done in a large lesion, and also a total removal of the scar tissue or keloid tissue cause significant deformity, especially in the like cartilage, in the on the air. Yeah, if it is too big, causing deformity, we choose the second option, partial excision. And how we close the defect? Yeah, in hypertrophic scar and keloid. This is very important to understand. Yeah, that in closing the bone. Yeah, first we should rely. Yeah, the tensile strength of the suture should be put on the fascia. Yeah, on the fascia. Yeah. The fascia on the muscle, the muscle fascia. Yeah. And then also on the superficial fascia, we could put there a minimal tension. Yeah, but on the dermal tension, dermal suture, yeah, should be minimal, very minimal. Yeah, and on the skin, no tension. We just approximate the skin. Yeah, so this is very important to know, to understand, especially by a young surgeon. Yeah, and also the resident maybe who join this program. Because the more tension that we put on the dermal, it will causing persistent inflammation of the reticular dermis. So that's why we should really put minimal tension. And the direction of the scar tension, yeah, we could alleviate, we could make it zero, yeah, by grafting it. Yeah, put a skin graft. Yeah, we put skin graft here as big as the size, but we prefer to use flap. Yeah, flap, especially like this pedicle flap, because the basis of this flap will enable the flap to elongate. Yeah, so will reducing tension in the future. Yeah, compared to we call it island flap. Yeah, we prefer use the pedicle one. And also we could distribute this the tension, scar tension, by performing setplasty or multiple setplasty. So this is the most important thing, yeah, that I want to say. So we have 4 approach. Yeah, total excision with primary closure, or core excision, or total excision with setplasty, or total excision with skin graft or skin flap. Yeah, so we could choose this one. First, we talk about hypertrophic scar. And assess the hypertrophic scar, we should assess whether the scar is inflamed, whether the scar is hard, hypopigmented, or any malignancy. And also the scar contracture, because it deforming the adjacent tissue and the adjacent anatomy. So we should assess the area of the tissue involved. Yeah, and also whether the bone is also involved. We should assess that one. The severity of contraction deformity, yeah, is also should be assessed. It depend on time, yeah, and interventional factors to the contraction itself. Yeah, so we could make a plan. We're doing scar excision, yeah, and then we release the contracture. And the bone and joint, if there is any malalignment, we should make it an alignment. And the last is defect coverage. I just share maybe 2 cases for hypertrophic scar. Yeah, these cases is a patient, yeah, with a bone injury. Yeah, you see here the won't heal per secundum, yeah. So that's why the scar is developed here, yeah. And also affecting the other leg. So both leg is affected by the scar tissue here. So this is, we call it hypertrophic scar because the scar is not growing beyond the original trauma or original wound, burn wound. Yeah. But in keloid, it will going much bigger than this. And we see the direction of contraction here. Yeah. So it will pull the leg here. So that's why the patient cannot walking, cannot straighten the leg. Yeah. So our goal is not just only remove the scar tissue, yeah, but we also should release the contracture. Yeah. So we call it flexion contracture on the popliteal region. And then we also need to assess the popliteal here. If the popliteal region is good, yeah, we could just simply release and put skin graft. We could straighten and put skin graft. But if the popliteal area here is exposed, especially the blood vessel here exposed, yes, we should consider a flap to cover this area. And sometimes we need like free flap too. And to assist the straightening the knee or the popliteal fossa, we also need to ask the patient when lying down at home or when sleeping, put the pillow below the heel here. It will help by the gravitational traction. Yeah. So the weight of the leg will straightening it slowly. Yeah. And this is 8 weeks post-op. The patient already start walking. Yeah. And then the second case, sir, here we see here, this is a female, 45 years old, already have 3 children. So during pregnancy, yeah, the abdominal skin here will expand. Yeah, will expand. Yeah, the patient got a burn injury. Yeah, it's also burn injury, and this injury also extend until the thigh. But I'm just showing here. Yeah, the inflammation that happen on the scar tissue here. Yeah. It's usually caused by follicular abscess because some follicular tissue here develop like an cyst, yeah. So it will producing inflammation, and we should first doing treatment for this inflammation before doing the surgery. Yeah. Due to prolonged contraction, yeah, the nipple here, yeah, will be move, yeah, will move into this direction, yeah, and also the breast tissue here, yeah, will move into this direction. It's to compress the parenchyma of the breast and also the nipple areola complex also like going downward, yeah. So we see here some hypopigmented skin also, yeah, and we should release this contracture and put back the navel, yeah, the nipple areola, yeah. We should doing release, yeah, and remove of the scar tissue here, yeah. So we should release, yeah, and we put we should put the nipple in new position by doing like abdominoplasty, we call it, yeah. And then the defect here we should cover, yeah, with a flap because this is a big defect, yeah. And we release the tissue here until the breast and also the nipple move upward, yeah. And this is the latissimus dorsi flap, yeah. We cover this defect. Yeah. So this is the position, yeah, of the navel back to normal. Yeah. But if you see here, the nipple is in one line, yeah, but the breast tissue is lack because the compression of the scar. So it's need maybe in the future like fat graft, yeah. But the patient is not yet come back again for the next procedure. That's about hypertrophic scar, and then next is about keloid. So the keloid is much more intense, yeah, and also much more prolonged inflammation. Yeah, some factors should be identified, yeah, before we treat the keloid with any specific disease related to the trigger, like acne or maybe smallpox, and then disturbance of the wound healing that happen. Like infection with any infection before, yeah, before development of the keloid, any granulation or maybe dehiscence. Also the foreign bodies, yeah, like piercing too. It's will irritating the wound, yeah, because not a pure gall that is used by the patient. Sometimes just like the piece of the earring is like produce irritation to the wound. And also we assess the tension in the area of the keloid and sites of predilection, and also the factor. So this is need more attention, yeah, because much more difficult to treat, yeah. But the principle is almost similar, yeah, almost similar with the hypertrophic scar, yeah. But we should really consider the use of suture material is also very important, yeah. We use less is much better because that produce less foreign body reaction. So this is the first case where I will show you how we conduct total excision with primary closure. Yeah, the aim or the goal is completely remove all the pathological scar yeah, with its symptom too, yeah, without igniting recurrence or new pathological scar. It could be done on small lesion, especially in the trunk area, yeah, and we should put, yeah, minimal papillary dermal tension suture, as I said before. So this is one of example, the keloid, yeah, on the chest, yeah. So here I show the fascia, yeah. The fascia is the key important for the tension, yeah. I mean the tensile strength of the wound, yeah. We should not put on the skin or on the dermis, yeah. So the dermis is and the skin should be very minimal tension. We just approximate the edge of the wound very loosely. And also in the keloid in the lobule area, like this, it is due to piercing in children 8 years old. We could doing total excision, and also we could close the wound primarily, yeah, without sacrificing the form of the lobule itself. Yeah? So this is the result. But you see here, we should remove the keloid through and through. Yeah. So from the front of the lobule until the, yeah, and then we put suture like this. And the second one is the core excision. So we just remove a part of the keloid. Yeah. This is done especially if close to the cartilaginous part of the ear, yeah. And if the lesion too big, and we just remove on the central part, yeah, on the core of the keloid. But of course, at the big keloid, we remove only partial resection. The cosmetic outcome is poor usually. So this is the keloid, also on the lobule. We just doing core excision by preserving the anterior part of the skin here, close to the cartilage here, just to preserving the lobule area here for the reconstruction. We could also total excision and septoplasty. Yeah, we're doing it if the lesion is 10 centimeter or more, or in the tense area. Yeah. But one thing is, if possible, make the septoplasty on the 60-degree design, not the 40-degree design. It will much better the result. So this is a children, yeah, a keloid on the retroauricular due to any vesicular reaction that igniting the development of the keloid. We're doing rotulation. You see here the keloid itself also got ulcerated here, and we remove and we put a septoplasty. This is around 6 months post-operation. So septoplasty is very helping. This is a keloid on the male on the supraclavicular area. Yeah. So it's around 10 centimeters long. Yeah. And then we remove total excision and we design multiple septoplasty. Yeah. This is just early result after operation. It will distribute the tension on the scar. It will distribute the tension on the scar because development of the keloid, yeah, is on this direction. And then total excision and skin graft or skin flap. Yes, the goal is eliminate all the scar or keloid and then the symptom itself. But the big defect should be closed with skin graft or skin flap. Yeah. So when primary closure is not possible, yes, we need skin graft. But flap is preferable than graft. And pedicle flap is preferable than island flap. So this is a children with a keloid on the dorsum pedis. Yeah. We're doing total excision and just put a full thickness skin graft. But 6 months, you see here, some recurrences, especially on the edge of the graft itself. So it's need really post-operative care. Yeah. What I use is just use a micropore taping. Yeah. But if possible, we could add some hydrocortisone cream too. Yeah. We plan to give injection, but the patient is not able to get the injection itself. Yeah. So just continue using the micropore tape, yeah, and also the elastic bandage. This is another case, multiple keloid on the auricular, retromandible, and on the neck. Yeah, this is a big keloid on the auricle. Yeah, we need a total excision, preserving the cartilage. Yeah, and we design a flap. Yeah, and we transpose the flap to cover the defect. Yeah, so we could maintain the form of the ear itself too. Yeah. This is early after surgery, but I'm not doing in one time. So I did in different times just to assess how the response of the keloid to surgery. I asked the patient to use micropore tip to, yeah, hydrocortisone cream too. Yeah. And then later we plan for the retromandible and also on the neck. Yeah. But you could see how the response here of the scar before. Yeah. Still red here. Yeah. So it's really need post-operative care. This also we close the defect. Yeah. We're doing total excision and then close the defect with a flap here. Yeah, this is a pedicle flap. And some part here we close primarily. So you see, we use the taping too, yeah. But here, some area here, yeah, especially close to the hair, is very, very easily developed keloid. Yeah, if it is close to hair or follicular area. And we give also steroid injection, but the patient cannot come always regularly. Yeah, but very important to make sure that the patient agree to do close follow up. Yeah, but during the pandemic, we have a big problem to follow up the patient. Yeah, and then in multiple keloid, we doing like before stent removal, and we should choose which one the proper surgical approach. Yeah, and the postoperative care is very important. Like in this boy, yeah, he has a keloid on the ear, yeah, on the mandible here, yeah, also on the nasolabial, yeah, on the chest here, yeah, on the contralateral side also, the mandible, and then also on the lobule area. So I did first put the ear, yeah. This is we taping. The patient is always use taping, and then we doing the second part here. Yeah, this is used by multiple set plastic here, yeah. And you see here some still inflammation. Yeah, it's like red. Yeah, we need to continue. Yeah, to use at least the cream. Yeah, and also the taping. And then for the area here, we put skin graft. Yeah. We put skin graft, and here we could remove primarily, and also on the chest we could close primarily. On the lobule here, this is a good result here too. Yeah. Sorry. I want to show how the progress of the skin graft. Yeah, it is the first few weeks after grafting. Yeah, and then we should put the taping like this. Yeah, it will getting better day by day. Yeah, but this taping is very important to reduce the tension and also to compress the skin graft and the new scar tissue. So this is very important to educate the patient, especially the parent in children. You see some redness of the scar here, yeah, but the contour of the ear still good. Yeah, you see on the set plastic here too. Yeah, yeah. This is the donor side is good. Yeah, yeah. So just taping, put steroid. Yeah, that's good. This is another case that very interesting. Yeah, dealt with keloid. On the right side, there is minimal keloid development, but on the left side is very big, and the pain, the patient complaining about pain, very painful. So when we ask the patient that the patient tried to got some treatment, and then the doctor gave a steroid injection and also doing operation, it is said. But we evaluate the patient with diabetes. Yeah, so maybe that is one cause that is not detectable. So we really should detect whether the patient with diabetes or not. Yeah. So this develop like this, and we're doing surgery after we control the blood sugar very well. This is the procedure that I did. We're doing total excision of the keloid. After we remove the keloid, we see the defect is getting bigger here. And then the second, we identify the perforator for our flaps. Yeah, we use a Doppler, and then we design the flap based on the perforator that we detect by the Doppler. So I hope it's so we just we use Doppler to detect the perforator. Yeah, where is the location of the perforator? Yeah, so that is a perforator. Sorry. And then we identify the perforator, this section. Yeah, we should dissect it. Yeah, doing a be very carefully to find the perforator. This perforator entering the skin, yeah, from the muscle, yeah, going to the fat tissue. Yeah. And then after that, we check using Doppler. Yeah, so we find the perforator. Sorry. Sorry. Why? Oh yeah, sorry. This one. So we tagging the perforator, that is the perforator that going into thread. And then we move the flap, yeah. So pedicle is better, but we cannot move this flap into the cranial direction highly, yeah. So we decided to make it like an island flap, yeah, by isolating the second perforator, yeah. So we could move the flap much more cranial. So this is after we could move the flap more cranial. Sorry. And then we could move, and then we close the defect here. Yeah. We use also micro port tape. This is just the new case that I make the video for this webinar, the last one. Yeah. So thank you so much, Dr. Peter, and also Prof. Maliawan. Yeah, I hope we can stop share now. Yeah.
Thank you very much, Dr. Nyoman Putu Riasa, for your nice presentation. And before opening the discussion, I would like to invite Dr. Johnny Dharmajaya to address the summary notes. Dr. Johnny Dharmajaya, the floor is yours.
Okay, thank you, Dr. Peter. Wow, good morning and good evening. Good morning for United States. Good evening for Indonesians. Wow, we have three presentations, very interesting this night in Indonesia, this afternoon, this evening. Firstly, from Dr. Made Widhi, she is a radiologist. Now we know the role of MRI for evaluation of brain tumors. So advance of MRI is more information we get from the brains, and she told us that three steps of using MRI for diagnosis, for treatment plan, and for treatment follow-up. And I noted there's more procedure, at least 8 procedure for MRI for brain, T1, T2 flare, T3 SWI, DWI, MRS, MR perfusion, DTI, and FMRA. Maybe I'm wrong, but that's a very interesting, Dr. Made. And okay, as a conclusion, MRI is more powerful for brain tumor evaluations. Okay, and the second presentation from Dr. Domingo Alvear is also interesting for me. This is the new thing for me. This is SMAS, superior mesenteric arterial compression syndrome, and a very complicated technique. And this is the rare. He told us that this is the rare disease, and newly knowing, maybe since 1980, we clearly know this after CT performs. And the third and the last presentation from Dr. Putu Riasa. This is everyday work of a surgeon, I think. Hypertrophic scar and keloid. Keloid is the more, so we fear about this situation because patient will come up and come again. Okay, very interesting presentation. We can open the discussion now. Thank you very much.
Thank you, Dr. Johnny, for the summary notes. And now I would like to open the discussion session. The first part of the discussion session is the inter-speakers discussion. So each speakers can ask question each other. And for the first opportunity, I would like to invite Dr. Madi Widyasih to ask question to the other speakers. Dr. Madi Widyasih, the time is yours.
Okay, thank you, Dr. Peter. I would like to ask the questions to Dr. Nyoman Putu Riasa, yeah, because actually I also have the hereditary for the keloid from my father, and I think it's very, very trouble because sometimes I don't know what is the cause is from the lesion, small lesion is become keloid. So I would like to ask to Dr. Riasa, if we perform the surgery for the keloid, is it still possible to the keloid recurrent in the future or not? Because the genetical is very more important of these cases. Thank you, Dr. Putu Riasa.
Thank you, Dr. Putu Riasa. Would you please react for this question?
Thank you so much, Dr. Widhi, for the question. That's a very important question, yeah, and also should very important education or explanation to the patient too, yeah, because the recurrence is our problem, yeah, our future problem, as Dr. Doni said. We should first recognize in the patient whether the patient has a genetic tendency or not. Yeah, this is the first screening that I did. How I did the screening, yeah. The patient normally has immunization on the deltoid, yeah. We could check that one, the BCG immunization during childhood. If there is no developed keloid there, the tendency, the genetic possibility is less, yeah, very small, yeah. And also we check also the earring, yeah, the earring. If the patient got earring and they develop no keloid there, so it means the genetic possibility not a big contribution, yeah. That is the first thing. And the second is whether the first wound, the first trauma is primarily heal good or not, yeah. The good wound healing normally will produce good scar, yeah. Or we should check whether the wound, the first wound before develop keloid, whether that wound got infection, whether that wound got proper treatment, for example, abrasion, just abrasion, if there is still some foreign bodies left there, it will producing inflammation. Yeah, so that's very important to evaluate the cause of the keloid itself. And the last is not the last, yeah, maybe the third is the surgical procedure that is done, because it's sometimes our colleague also refer the patient with the keloid. We also should really make knowing, but it's very difficult to find out with the, what kind of suture material that they use. This is very important too. Yeah, and then the last time is the last evaluation is whether the area is a movable area. I mean, with much movement, yeah, motion on the area, close to that area. For example, like on the knee, yeah, and then on the deltoids, and on the chest, there is a movement. So we should restrict the movement, yeah, by taping, yeah, by using the elastic bandage, yeah, or the garment, like elastic garment. But also, we need sometimes to change the habit of the patient, yeah, change the habit, I mean, the lifestyle. If they always use that area, for example, the knee, yeah, the activity that involving the area should be reduced. Another option is radiation, but it is not yet able to be done in Indonesia. Yeah, but another prevention is steroid and 5-fluorouracil. Yeah, so it's still possible. We should explain to the patient, but as long as we doing without tension, normally the scar is we able to control it. Yeah, and the follow-up needed at least 1 year. We should follow up. Yeah, but this is the problem. Sometimes the patient cannot really come until 1 year, until the scar getting mature. It's very difficult. That is my answer, Dr. Widhi. I hope you satisfied.
Yeah, thank you, Dr. Riasa, for your explanation. For the next opportunity, I would like to invite Dr. Domingo Alvear. Do you have any question to the other speakers? The time is yours.
Yeah, the problem with keloid is common in the US with the patients from the Black population. And I've seen this myself, and I follow some of the principles you have described. So I don't have any questions. I just learned from the flap idea with following perforator seems to be something that people have to look into, because whenever you excise something, it's very difficult for that big tissue to come back. You know, so the idea of creating a different kind of flapping will be most important. Right.
Thank you, Dr. Alvear, for your feedback. The next, I would like to invite Dr. Riasa to ask question to the other speakers. Dr. Riasa, time is yours.
Okay, thank you. First is to Dr. Widhi, yeah, but I don't know, because now the radiotherapy may be different with the radiology department, yeah, but maybe, you know, some possibility or not to developing the radiation therapy for keloid in our hospital. Maybe that is one of my question. And the second question is to my senior, Dr. Alvear. We in burn patients, sometimes we found that the patient develop, we call it superior mesenteric artery syndrome. We do not know why it's happened in a burn patient, yeah, and it still may be possible the patient have a but like a congenital predisposition, yeah. But one of the difficult thing to diagnose in burn patient is the superior mesenteric artery syndrome, that mostly occlusion of the artery. Maybe if you have an idea of how we could diagnose in burn patient, especially because in burn patient, the motility of the gaster and also the intestine, yeah, the GI tract is very slow, yeah, lowering the peristaltic and also the motion. And in some patients, it's also developed like we call it compartment syndrome, abdominal compartment syndrome, yeah. If the patient with a burn scar on the abdomen, yeah, the compartment syndrome develop especially after resuscitation, after fluid resuscitation. So maybe I need also advice from you if you could help give some idea how to we could detect, and maybe what is the first treatment or the first action that we could do in that patient. Thank you so much.
Thank you, Dr. Riasa. Dr. Widhi, would you please react for the first question to Dr. Riasa? Time is yours.
Thank you, Dr. Peter. Thank you, Dr. Riasa, for your questions. I think it's possible to us to apply the new technique for the keloid with the radiation in our hospital, but honestly, this is not my responsibility to answer the question, because the radiotherapy is the different department from the radiology diagnostic. Maybe I suggest you to make the collaboration with the radio-oncologist therapist with the Dr. Mahendra or Dr. Daksa to develop the new treatment for the keloid. I'm very supporting for this if can develop in our hospital. Thank you, Dr. Riasa.
Thank you, Dr. Widhi. Dr. Alvear, would you please react for the next question of Dr. Riasa? Time is yours.
Okay. Whenever you have a severe burn, you have severe catabolism. So you have a negative nitrogen balance. So you certainly lose a lot of weight. And as you mentioned, there's sometimes the motility of the GI tract is also a problem. So you need to give them, when there's a SMA syndrome with those patients, you probably need to do a nasojejunal feeding to help with the catabolism, so you can bring the patient back to a positive nitrogen balance. So it's difficult. I don't think surgery is the first approach to that condition. You have to do nutrition is the first thing, whatever you have, whatever means you can give them.
Right. Thank you, Dr.
Thank you so
Alvear.
much.
Yeah. For the next opportunity, I would like to wish a welcome to Dr. Shin Miyata to this webinar. Do you have any question, Dr. Miyata?
Yes. First of all, Dr. Manapa, thank you for inviting me and our team to this conference, and I really enjoyed it. My name is Shin Miyata. I'm a pediatric surgeon in St. Louis. I have a question, Dr. Alvear. So the question is about patient selection. We don't see SMA syndrome very often, but every now and then we get consulted for the patient who may have SMA syndrome. And I think there's a lot of like gray zone in terms of diagnosis. And at some point, the patients sometimes get labeled as being crazy because, there is some component, psychiatric component as well. So what kind of patients do you think benefit from the surgery? And also, the results of the surgery may be good, but how many of those patients would have gotten better without surgery? Sometimes we can do like a small frequent meals and they put on weight and symptoms get better. So I just wanted to ask you about the patient selection.
Thank you, Dr.
Good.
Miyata, for the question. Dr. Alvear, would you please explain about this question? Time is yours.
Yeah, this is an excellent question from Dr. Miyata, actually, because a lot of the patients actually die because they've been labeled as crazy, and they get very despondent about the answers themselves, because we don't know which one came first, whether the symptoms or because they were crazy to begin with. And labeled cyclic vomiting, they've been labeled anorexia nervosa, and they've been labeled all kinds of psychosomatic diseases, except for the SMA. But once you have a anatomic diagnosis using the MRI or the CT, and you have to, like the radiologists always say, you have to correlate the findings with the symptoms, and that's how you do it. Is once they tried all kinds, if they tried, for example, TPN or feeding, nasogastric feeding, and didn't work, the patient continues to vomit, especially if they start vomiting bile, there's a problem, because if they only vomit when they eat because they want to be anorectic and they don't want to gain weight, and that's a different issue. But when they start vomiting bile and they have a lot of pain, then you have to look into those possibilities. And the problem with the diagnosis is sometimes if you don't catch the acute phase, and you don't do the study at the acute phase, it might not be positive for when you do a diagnostic study later, 2 days, 3 days later, you might not get the diagnosis. So you really have to individualize the patient. And the ones I've seen, they've been in many doctors. I have a patient been transferred from other institution. I have one from Canada, and she was in morphine for about 2 years. So before I could accept her, they have to take her out of opioid dependency, so I can assess the patient better. And now she's 8 years later, she's doing very well now after I did the derotation and duodenojejunectomy. So
Thank you.
a lot of my, yeah. So it's difficult.
When surgery goes well, how do patients do? Like, do they feel immediate relief after surgery?
Some do, and some takes a while. Like I've seen patients. It depends on if you have a patient. For example, I have a patient who's Amish, who's never been on drugs, never been on psychiatrists, never been to many doctors, and you operate on those patients. They do beautifully because they've never been exposed to all kinds of other problems. So those patients who have been exposed to many physicians, psychologists, psychiatrists, they might have some time to get over it. It may take 6 months to a year.
Thank you.
Thank you. Yeah, thank you, Dr. Miata and Dr. Alvear. I have any question from the floor? While waiting for the other question, I would like to know about the diagnostic laparoscopy for SMEC. I would like to know the opinion of Dr. Alvear and Dr. Miata. To what extent could we use the laparoscopy to confirm the diagnosis of this disease? Thank you. Maybe Dr. Alvear first.
Yeah, definitely laparoscopy is being done to diagnose it. But if you do that, might as well, if you have decided that the patient may have it and you proceed with laparoscopy, you can do the division of ligonotrytes through laparoscopy, and then you can do the derotation, make a smaller incision to to proceed with the fixation and the final derotation. But initially, you can do a laparoscopy. There's no good laparoscopic finding yet that you could say this is it. Yeah, it has to be correlated with the symptoms and what you've seen with the patient.
Thank you, Dr. Alvear. Dr. Miata, how about your perspective on this disease with laparoscopy?
I don't have a lot of experience, but I think when it comes to diagnosis, I think preoperative imaging and history, like Dr. Alvear mentioned. But as with regards to the therapeutic, advantage. I've only done one laparoscopic procedure for the SMA syndrome, but that was not a derotation like Dr. Alvear described. So maybe next time I'll try laparoscopic derotation. I think it's possible, technically feasible.
Thank you, Dr. Miyata. And any other question from the floor?
From the floor, yeah. There is one question from the floor.
Please ask directly, introduce yourself, and then to whom you address the question. Please.
Ngakan?
Thank you. I'm Dr. Ngakan from Bali, Indonesia. I would like to ask one question about superior mesenteric artery syndromes. I have faced some cases about superior mesenteric artery syndromes, but the patient came with an acute abdominal sign. So we suspected these patients without further diagnostics supportive. I want to ask about these questions to the speakers. Have you ever faces the superior mesenteric arteries patients with which came with an acute abdominal signs? And in my cases, we found that the necrotics on the jejunum and ileum, and the patient needs excision of resections of the ileum. Have you ever seen these cases similar to our cases on your center? Thank you, doctor.
Thank you, Dr. Ngakan. Maybe first, I would like to give the turn to Dr. Alvear.
What you're describing is SMA syndrome, because we don't usually see any acute episode where there's a dead bowel or dead jejunum or something like that. It's a chronic syndrome with, and you have a cellulose to go along with an acute episode, because the acute episode in SMA syndrome is not ischemia. It doesn't have to do with ischemia of the bowel. It's compression on the duodenum, which causes some kind of a partial obstruction. Very few complete obstructions. You lay on your right side down, or you can lay on, but never a problem with. So unless reasons for the ischemia, we don't see that.
Okay, thank you, Dr. Alvear. Dr. Miyata, do you have any comment on this case?
No, nothing in particular.
Okay, thank you. Maybe one more question from the floor. Good. If there is no question, I would like to invite Mr. Max Downham to address the closing speech. Mr. Max Downham, time is yours.
Dr. Manopo, thank you very much. And the Indonesian section leadership, you are fantastic conducting these. I have 3 or 4 quick points. Number one, the presentations. First of all, I should say I'm not a physician. I'm in science and chemistry, and so I'm really not qualified to render any kinds of comments here. except with the acknowledgement I just made. Given that, I think the presentations are excellent. The slides are excellent. I congratulate all of the speakers. I think you just did a terrific job. Second point is that, you know, the International College of Surgeons, a word about what the ICS is all about. The International College of Surgeons is 87 years of age, founded in 1935. One of the legacy points of Dr. Max Thorek, the founder, a Hungarian surgeon, is that the thesis is that you are both a teacher and student at one and the same time. And it seems to me that this webinar has demonstrated that for sure. The third point is that there are 4 missions of the college. They are education, communications, presenting research data, and leadership. And it seems to me that all of those 4 missions, Dr. Manopo, have been really addressed in this excellent webinar. And finally, about Dr. Domingo Alvear, you should know, if you don't know, that he is a great humanitarian surgeon who has done many humanitarian missions. He is the head of what is called the World Surgical Foundation, and that foundation is celebrating, I believe, this year, and correct me, Dr. Alvear, if I misspeak here, 25 years. So it is the 25th anniversary of Dr. Domingo Alvear's founding of the World Surgical Foundation. So with that, Dr. Manopo, thank you so very, very much again for giving me the opportunity to participate in this manner, Thank you.
Thank you very much, Mr. Max, for the closing speech. On behalf of the International College of Surgery Indonesia, I would like to express deeply my gratitude to our guest speaker, Dr. Alvear, and the other speakers, Dr. Widhi and Dr. Riasa, also for Mr. Max Downham, the World Executive Officer, and Dr. Johnny Dharmajaya, the Vice President of the Indonesian section, all participants, and our IT team, Mr. Bimo and Ms. Devi. Thank you very much for your good cooperation, contribution, and for your attention. We will meet next month with the other topic and other speaker. Thank you very much, and stay well and healthy. Good night and goodbye.
Thank you.
Goodbye.
you.
Thank you.
Thank you.